I mentioned the power of the data and really the tools that this therapy brings to the management of persons with epilepsy. And there's no better person to speak to that than my colleague and friend and frequent collaborator, Dr. Vikram Rao.
Good morning, everyone. Thanks, Marty. It's really a privilege for me to be here to share my experience taking care of people treated with the RNS system now for over 10 years. But I think I'm going to start this talk on the power of RNS data with a thought experiment that I'll ask you to indulge me. So imagine for a moment, imagine that you're an investor or an analyst and you're charged with picking a stock, but you have no historical information on the past performance of that stock and any quantitative information that you might have. What little information you do have about that company is probably inaccurate. And yet you have to do something. I'm not talking about NeuroPace, by the way. I just gave Joel a heart attack. But you have to do something with information that is inadequate. And that feeling, that unsettling feeling, is really what it is to be a clinical epileptologist, because epilepsy is in many ways a black box. There is no blood test that helps us gauge the severity of epilepsy. When we do short-term recordings of brain activity with EEG, they are often normal. Even people who have poorly controlled epilepsy spend the vast majority of their time not having seizures. And when somebody comes to my clinic and they do the best they can telling me how it's going, how many seizures they've had recently, whether the interventions that we're doing are helping or not helping, do the best they can. And I know that their report is likely to be mostly inaccurate, unfortunately. And yet I have to do something. And I tell our trainees that epilepsy, clinical epilepsy, is the art of making incredibly consequential decisions with woefully inadequate information. And that is where data from the RNS system has been truly transformative. As Marty said, we call it a window to the brain, which is actually not just a marketing phrase. That is actually true. That is true. This has been kind of a game changer in our field because the RNS system and data from it helps us to learn about a patient's epilepsy, to personalize the therapy that we offer to that individual, to monitor in a quantitative way their disease severity over long periods of time. And all of this, by the way, is with somebody in their home environment, normal activities, on medications over months to years. There is no other way in neurology to do that. And so this slide really shows a few examples. This is certainly not, it's a busy slide and it's not exhaustive. It just gives you a few anecdotes of what we do as clinicians with this data, this really precious data set that we have. In the upper left, you see what happens when we introduce a new anti-seizure medication. Sometimes we see a precipitous drop, an immediate drop in the rate of detections of abnormal activity, like the sparks that the device is hearing suddenly plummet. That portends a favorable long-term response to that medicine. If we don't see a drop like that, that suggests that maybe that medicine isn't the best one for the individual. We talk about tracking seizures, and you might think we could just ask our patients, well, how many seizures are you having, and base our therapy based on that. But in fact, it's not that simple. It's a very common scenario in my clinic when I ask somebody, how many seizures have you had since I last saw you? And they say, I've had 3. And I look at their RNS data and say, you've had 30. That happens all the time. But with the RNS system, we can track electrographic seizures. That just means an electrical recording of a seizure that's objective. I can see it in the data. I can count it. I can trend it. I can relate it to interventions that I'm doing, behavioral interventions that I might make, a new medication, a surgery that I might offer a patient. I can track biomarkers of a disease. I can look at this rate of sparks of abnormal brain activity in our patients, for example, and look at interesting trends like day-night variation, so-called circadian variation. We can look at cyclical fluctuation in relation to things like menstrual cycles, and all of this helps us to optimally manage a given individual. But what do we do before the RNS system? I mean, we did something, right? Well, what we did, the gold standard, is still bringing somebody into the hospital to a specialized inpatient unit called the Epilepsy Monitoring Unit, or the EMU. And this is a place where we glue on some surface electrodes, we record brain activity over a handful of days, usually not more than a week. Insurance companies give us grief if we keep people longer than a week. And we do all kinds of things. We keep people up at night, we sleep deprive them, we strip them off their medicines, we shine lights at them, we make them have seizures. And after 4 or 5 days, we conclude, okay, we understand what's going on with their epilepsy. And that is really kind of a problem because epilepsy, I would argue, is the most dynamic disorder in all of neurology. And so recording somebody for 4 or 5 days is just a massive temporal undersampling problem. Okay, not to milk the finance analogy too much, but that would be like tracking the Dow for like 4 days and seeing it downtrend and concluding that we're in a recession. I mean, that's ridiculous, right? Because you know that this is an intrinsically noisy variable that has to be followed for longer periods of time. And it's actually the exact same in epilepsy. If I have somebody for 4 days in my EMU and I record 2 seizures from the left side, am I very sure that they couldn't possibly have seizures from the other side? Sometimes not. And I think that was really nicely exemplified by this study, kind of a classic study now by one of my colleagues, Dr. King-Stevens. And this is a complicated slide. Let me walk you through this. It's actually simple what they did. They went to the RNS system clinical trials. They pulled out the 82 patients who had 1 lead wire in each temporal lobe. Why? Because the clinicians who were taking care of them had reason to suspect that this person, these people, could make seizures independently from both temporal lobes. So they were implanted bilaterally, and then they were followed. And this graph, each bar is one of those individuals, and the length of the bar is showing you the duration of time between when you record 1 seizure from one side and at least 1 seizure from the other side, meaning how long did it take to prove that, in fact, yes, they could make seizures from both sides of their brain. And the punchline is that it takes a surprisingly long amount of time. In this study, an average of almost 42 days, with 2/3 of people taking more than a week to prove that they could make seizures independently from both sides. Why does that matter? That matters because I just finished telling you that our EMU admissions typically don't extend beyond a week. So again, a temporal undersampling problem. This cartoon sort of makes that point in a different way. So the cartoon characters here are shaded either blue, which means all seizures from the left, purple meaning all seizures from the right, and the shades of color are something in between left and right seizures. The top row is what you saw in the EMU. The bottom row is what you see in long-term real-world follow-up with the RNS system. And the X's indicate the 7 out of 12 patients where there's a mismatch, where the conclusion that you made during your short-term recording in the artificial circumstance of the hospital is different than what you found in long-term real-world follow-up. Why does that matter? That matters because if we incorrectly lateralize somebody, we might refer them for an incorrect surgical procedure. And once you take out a part of the brain, you can't put it back. So it's a big deal. It's really a big deal. We don't want to make incorrect surgical decisions that don't help people. There's a lot of data that comes from the RNS system. I made this figure a few years back just to summarize some of them. I wish I had time to really tell you about all of the different forms in which data comes to us. And clinicians, if you ask them, always want more data, right? But the response to getting that data, usually in my experience, is sort of a biphasic response. First response is, yay, we have a ton of data to look at. Second response is, oh darn, we have a ton of data to look at. And that is actually the clinical challenge. The challenge is taking mountains of data and distilling from that the core information that actually helps me manage a patient clinically. Because I don't need to see everything. I just need to see the most important things. And so what do? Well, typically, I manually sort of look through all the recordings, all the data, extract the things that I think are actually useful. And that is fine. There's a certain fun to that, but it does take time. It is not efficient. It is not scalable. And luckily, all of this is about to get much more streamlined. This is the landing page for the Patient Data Management System, PDMS, that Dr. Morell told you about. This is where clinicians go. You fire up a patient's account, and this is where we can go and look at graphical representations of trends of activity. If you're with a patient, you can look at live streaming recordings of brain waves. You can look at a library of stored clips of brain activity data. You can look at current and past programming settings on the device. And the green pane is sort of a aspirational or emerging functionality of PDMS. That's called AI-powered seizure trends. And when clinicians click on that box, it will open up essentially a toolkit of things that are going to make our lives a lot easier. One of those tools is a sorting tool. So we have this library of many, many hundreds, sometimes thousands of recordings to look at. And sometimes the only ones that I actually care about are the ones that have seizures. That's really what I want to know. That is the essential information. And I can go through with my eyes and pick out the seizure recordings. I can do that. But it turns out that a well-trained AI-based algorithm can do that as well, maybe better than me. And that has now been validated and soon will be a functionality that with a click of a button, an AI-based tool can pull out all the seizures and show them to me really in a simple way. And we think that that will not only streamline the process of programming these devices, but actually save clinicians a lot of time. Another huge time-saving tool that will be available is shown here. So one of the most, I'll say tedious, but maybe time-consuming is the better term, is teaching the device how to identify seizures. At the end of the day, the RNS system is a computer, which means we have to tell it what to do. And we want it to detect seizures as early as possible. Why? So that when it detects a seizure, it can intervene and try and stop that seizure. The better we can detect seizures, the more effective the therapy can be. And currently, we configure a variety of computational tools manually to identify seizures with high fidelity. That's fine. That's what we do. But it turns out, again, AI can do that better than me. And through validated algorithms now, there are ways that AI can select the onset of a seizure and do probably a better job and help me treat that seizure earlier than I would have otherwise, and also save me a lot of time. I take care of about 150, 160 people treated with the RNS system at my practice. And I would be lying if I said to you that every single one of those people has a fantastic outcome with the RNS system. That is definitely not true. Some people are not doing as well as I would like. That is the reality. But I have to believe that a part of the reason why they're not doing better is that I have not programmed the optimal settings on their device. Why? No lack of effort on my part. It's just that I don't know. This is largely an empiric, again, largely a black box sort of enterprise here. I don't know what the best settings are for that patient. But now that there are actually thousands of people treated with the RNS system, why not leverage that big data and have an algorithm go and find patients with clinical similarities to my non-responding patient, and to show me patients who are doing better and leverage knowledge from that to apply to my patient. So that seems like a pipe dream. That is now actually going to be a reality. Deep learning algorithms can mine large data sets. They can extract information that will suggest settings that will be better for my patient. A method called Bayesian optimization is just a way to use data from every patient to predict the next best settings for my patient and hopefully achieve better outcomes in a way that I don't have to be any smarter. I can actually lean on the algorithm to guide me. So again, the take-home message from this section really is that the tools that are on the way are not only helping to save clinicians time and make things easier for us, with the presumption that the easier this is for clinicians to use, that will drive volume, but also, more importantly, to improve efficacy for seizure reduction in our patients.